Welcome to NSG 323, Study Session 14, Hydratidiform Mole. Introduction. Hydratidiform mole is an infrequent form or growth that forms inside the womb, uterus, at the start of a pregnancy. It is a kind of gestational trophoblastic disease, GTD. A cancerous form of GTD is called choriocarcinoma. Causes: hydratidiform mole or molar pregnancy. Consequences from overproduction of the tissue that is hypothetical to develop into the placenta. The placenta feeds the fetus during pregnancy. With a molar pregnancy, the tissues grow into an irregular growth called a form. Learning outcome: molar pregnancy, natural history, parental origin, clinical presentation and diagnosis. Molar pregnancy. Molar pregnancy is an abnormal form of pregnancy in which a non-viable fertilized egg implants in the uterus and converts a normal pregnancy into an abnormal one, which will fail to come to term. A molar pregnancy is a gestational trophoblastic disease that grows into a mass in the uterus that has swollen chorionic villi. These villi grow in clusters that resemble grapes. A molar pregnancy can develop when an egg that is missing its nucleus is fertilized and that may or may not contain fetal tissue. It is characterized by the presence of a hydratidiform mole or hydatid mole, molar hydatidosa. Molar pregnancies are categorized into partial and complete moles. Mole, as used here, simply indicates clump of growing tissue or a growth. A complete mole is caused by a single 90% or two 10% sperm combining with an egg which has lost its DNA. The sperm then reduplicates, forming a complete 46 chromosome set. The genotype is typically 46XX diploid due to subsequent mitosis of the fertilizing sperm, but can also be 46XY diploid. 46YY diploid is not observed. In contrast, a partial mole occurs when an egg is fertilized by two sperm or by one sperm, which reduplicates itself, yielding the genotypes of 69XXY triploid or 92XXXY tetraploid. Complete hydratidiform moles have a higher risk of developing into choriocarcinoma, a malignant tumor of trophoblast cells, than do partial moles. The etymology is derived from hydatisia, Greek, a drop of water, referring to the watery content of the cyst, and mole, from Latin mola, millstone, false conception. The term, however, comes from the similar appearance of the cyst to a hydatid cyst. Hydratidiform mole conception may be categorized in medical terms as one type of non-induced, natural, missed abortion, referred to colloquially as a missed miscarriage, because the pregnancy has become non-viable, miscarried, but was not immediately expelled, therefore was missed. One form of gestational trophoblastic disease, a molar pregnancy, results from abnormal fertilization of the ovum. A complete hydratidiform mole, shown here, occurs when the ovum is lacking a maternal complement of chromosomes and is fertilized by a haploid sperm, usually containing an X chromosome. Duplication of this chromosome set typically yields a 46XX karyotype that is paternally derived. No fetus develops, but there is an abnormal placenta consisting of a mass of tissue with grape-like swollen chorionic villi. Natural history. A hydratidiform mole is a pregnancy in which the placenta contains grape-like vesicles, small sacs that are usually visible with the naked eyes. The vesicles arise by distension of the chorionic villi by fluid. When inspected in the microscope, hyperplasia of the trophoblastic tissue is noted. If left untreated, a hydatidiform mole will almost always end as a spontaneous abortion, miscarriage. Based on morphology, hydatidiform moles can be divided into two types. Incomplete moles. All the chorionic villi are vesicular and no sign of embryonic or fertile development is present. Partial moles. Some villi are vesicular, whereas others appear more normal, and embryonic or fetal development may be seen, but the fetus is always malformed and is never viable. Hydatidiform moles are a common complication of pregnancy, occurring once in every 1,000 pregnancies in the US, with much higher rates in Asia, e.g., up to 1 in 100 pregnancies in Indonesia. D. Hyacinthe, Parazini, Rosa, Chetnod, Benzi, 1997. In rare cases, a hydatidiform mole coexists in the uterus with a normal, viable fetus. These cases are due to twinning. The uterus contains two concept juices, one with an abnormal placenta and no viable fetus, the mole, and one with a normal placenta and a viable fetus. Under careful surveillance, it is often possible for the woman to give birth to the normal child and to be cured of the mole. The etiology of this condition is not completely understood. Potential risk factors may include defects in the egg, abnormalities within the uterus, or nutritional deficiencies. Women under 20 or over 40 years of age have a higher risk. Other risk factors include diet low in protein, folic acid, and carotene. The diploid set of sperm-only DNA means that all chromosomes have sperm-patterned methylation suppression of genes. This leads to overgrowth of the syncytiotrophoblasts, whereas dual egg-patterned methylation leads to a diversion of resources to the embryo with an underdeveloped syncytiotrophoblasts. This is considered to be the result of evolutionary competition with male genes driving for high investment into the fetus versus female genes driving for resource restriction to maximize the number of children. A small percentage of hydatidiform moles have biparental diploid genomes, As in normal living persons, they have two sets of chromosomes, one inherited from each biological parent. Some of these moles occur in women who carry mutations in the gene, predisposing them towards molar pregnancy. This rare variant of hydatidiform mole may be complete or partial. Clinical presentation and diagnosis. The following are symptoms of molar pregnancies. Painless vaginal bleeding in the 4th to 5th month of pregnancy. The uterus may be larger than expected. The ovaries may be enlarged. There may also be more vomiting than would be expected, hyperemesis. Sometimes there is an increase in blood pressure along with protein in the urine. Blood tests will show very high levels of human chorionic gonadotrophin, HCG. The diagnosis is strongly suggested by ultrasound, but definitive diagnosis requires histopathological examination. On ultrasound, the mole resembles a bunch of grapes, cluster of grapes, or honeycombed uterus, or snow storm. There is increased trophoblast, proliferation, and enlarging of the chorionic villi. Angiogenesis in the trophoblast is impaired as well. Sometimes, symptoms of hyperthyroidism are seen due to the extremely high levels of HCG, which can mimic the normal thyroid stimulating hormone, TSH. Examinations and tests. A pelvic examination may show signs similar to a normal pregnancy, but the size of the womb may be abnormal and the baby's heart sounds are absent. There may be some vaginal bleeding. Diagnosis. A pregnancy ultrasound will show an abnormal placenta with or without some development of a baby. Tests may include HCG blood test, chest X-ray, CT or MRI of the abdomen, complete blood count, blood clotting test, kidney and liver function tests. Diagnosis and treatment. Treatment. Hydatidiform moles should be treated by evacuating the uterus, by uterine suction, or by surgical curettage as soon as possible after diagnosis in order to avoid the risk of choriocarcinoma. Patients are followed up until their serum human chorionic gonadotrophin HCG level has fallen to an undetectable level. Invasive or metastatic moles, cancer, may require chemotherapy and often respond well to methotrexate. As they contain paternal antigens, the response to treatment is nearly 100%. Patients are advised not to conceive for 1 year after a molar pregnancy. The chances of having another molar pregnancy are approximately 1%. Anesthesia management. The uterine curettage is generally done under the effect of anesthesia, preferably spinal anesthesia in hemodynamically stable patients. The advantages of spinal anesthesia over general anesthesia include ease of technique, favorable effect on the pulmonary system, safety in patients with hyperthyroidism, and non-tocolytic pharmacological properties. Additionally, by maintaining patients' consciousness, one can diagnose the complications like uterine perforation, cardiopulmonary distress, and thyroid storm at an early stage than when the patient is sedated or is under general anesthesia. Management is more complicated when the mole occurs together with one or more normal fetuses. Carboprost, PGF2A medication may be used to contract the uterus. Prognosis. More than 80% of hydatidiform moles are benign. The outcome after treatment is usually excellent. Close follow-up is essential. Highly effective means of contraception are recommended to avoid pregnancy for at least 6 to 12 months. In 10 to 15% of cases, hydatidiform moles may develop into invasive moles. This condition is named persistent trophoblastic disease, PTD. The moles may intrude so far into the uterine wall that hemorrhage or other complications develop. It is for this reason that a post-operative full abdominal and chest X-ray will often be requested. In 2 to 3% of cases, hydatidiform moles may develop into choriocarcinoma, which is a malignant, rapidly growing, and metastatic spreading form of cancer. Despite these factors, which normally indicate a poor prognosis, the rate of cure after treatment with chemotherapy is high. Over 90% of women with malignant, non-spreading cancer are able to survive and retain their ability to conceive and bear children. In those with metastatic spreading cancer, remission remains at 75 to 85%, although their childbearing ability is usually lost. The prognosis of hydatidiform moles can be estimated by scoring systems such as the modified WHO prognostic scoring system, wherein scores between 1 and 4 from various parameters are summed together. Complications of molar pregnancy. Complications normally occur during molar pregnancy, which hinder easy delivery of the baby and affect the mother. The following are the complications of a molar pregnancy: preeclampsia, thyroid problems, molar pregnancy that continues or comes back. Complications related to the surgery to remove a molar pregnancy include excessive bleeding, side effects of anesthesia. Summary. In study session 14, you have learned that molar pregnancy is an abnormal form of pregnancy in which a non-viable fertilized egg implants in the uterus and converts a normal pregnancy into an abnormal one, which will fail to come to term. Natural history. A hydatidiform mole is a pregnancy in which the placenta contains grape-like vesicles, small sacs that are usually visible with the naked eye. Hydatidiform moles can be divided into two types: incomplete moles and partial moles. Clinical presentation and diagnosis contain the following symptoms: painless vaginal bleeding in the 4th to 5th month of pregnancy. The uterus may be larger than expected. The ovaries may be enlarged. There may also be more vomiting than would be expected. Hyperemesis. Sometimes there is an increase in blood pressure along with protein in the urine. Blood tests will show very high levels of human chorionic gonadotrophin (HCG). Anesthesia management. The uterine curettage is generally done under the effect of anesthesia, preferably spinal anesthesia in hemodynamically stable patients. End of study session 14 and end of NSG 323. Thanks for listening.